Hello, everyone, and thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University, beautiful downtown Brisbane, and today I'm delighted to be joined once again by Phillip Helliwell, Professor of Rheumatology at the University of Leeds in the UK. Phillip is one of the original Graphites who set it up. Phillip is one of the thought leaders throughout the world in psoriatic arthritis, and one of the few people that does original research to answer important original questions. It's a pleasure to have you join me today, Phillip, to discuss your recent publication, which I found very interesting. It's almost a follow-up of the TICOPA study, one of the only strategy studies in psoriatic arthritis, and it's looking in particular at whether the tight control of TICOPA had an effect on radiological progression and the radiographic outcome. So welcome, Phillip, and thank you so much for your time. Can you give us a bit of a rundown for those who either don't know or have forgotten what TICOPA was and how important it really was to the field of psoriatic arthritis?
Yeah, thank you. And it's a pleasure to be with you again, Peter. On a very cold morning here, and I'm presumably a sunny evening with you.
Only 32 degrees today.
So TICOPA, was the first strategy study in psoriatic arthritis that looked at achieving tight control over a 12-month period. Did it have better outcomes than standard care? There wasn't a placebo arm, so the standard care arm were treated by consultant rheumatologists. So the contrast in treatment outcomes is always going to be narrow at the best. But we conducted that study way back now, about 10 years ago, or possibly more, and did find that treating to target, that is reviewing the patients regularly, changing their treatment if they weren't reaching the target, which was minimal disease activity, doing that for 12 months gave better outcomes in terms of joints and skin, health-related quality of life, and other clinical outcomes. But it was at a cost because we used more biologics over that 12-month period. But at that time, of course, biologics weren't off-label, as it were. There were no biosimilars available. But we've since published a reanalysis of the cost-benefit with biosimilar prices and shown that treating to target is in fact cost-effective in the long run.
Now, what about the downside of increased SAEs? Because at the time, most of the escalation was to a TNF, and there was a cost for using TNFs in this patient population.
Yeah, there was a financial cost, as I've just mentioned, but also a clinical cost in terms of adverse events. It wasn't dramatic, but it's the sort of increase in adverse events you'd expect with a biologic drug, such as an anti-TNF. There were no other categories of drug available then. So, yeah, that was the downside. But on both of the arms had problems with methotrexate because we were using big doses, 25 milligrams of methotrexate. So there are lots of liver function abnormalities and such like. I mean, I must say, I was very wary. One of the patients in the study, a little old lady of 84, frail little thing, was randomized to get 25 milligrams of methotrexate in the tight control arm. And I was so worried, but she was fine. She sailed through it. But so you can't predict, really, as you know, who's going to get what problem. But on the whole, there were more adverse events in the tight control group.
And were there ones to worry about, Phillip? Serious infective episodes and that kind of thing?
Yeah, but these patients had other comorbidities, and in a normal run of things, you'd be a little bit wary about the treatment you selected for them. But because they were in a trial, as I say, I'd have been wary about this frail 84-year-old and would have not escalated as such in her. But the patient, I think two of the patients who had serious infections had diabetes and other comorbidities. that we had to, that may have increased their chances of getting infections with TNF.
And it's a shame of the timing of such an important trial, because do you feel the 17 and the 23 inhibitors have a better safety profile than those agents we used to use?
Yeah, I think that's true, and I think we all believe that now. But having said that, Peter, I still reach for a TNF inhibitor for my first biologic in these patients. I suppose it's going to be very hard to change my habits.
But Philip, that's not evidence-based, because the efficacy is almost impossible to distinguish between, say, the 17 and the TNF in a head-to-head. So if one's the same efficacy but safer, I would ask you to reconsider.
Well, except the cost issue, you know, we get biosimilar adalimumab now is cheap as chips in the UK, and that's one reason why we do that, because it's much more cost effective in that way.
Well, they do. The biosimilars have made a big difference here as well. They've really halved the cost for a year of a TNF, but they tell me I can treat more people because it's cheaper. But until they change the restrictions of access, I can't treat more people.
Yeah. Well, you've always had very draconian restrictions, haven't you?
We do. We have to have 20 swollen joints despite 2 agents for 6 months.
You have to use your imagination. Yeah.
It's very rubbery sometimes, that's true. Tell me about this paper and tell us a little bit about what X-ray outcomes you looked at.
Okay, well, we built into the study an X-ray outcome, hands and feet X-rays with a modified sharp Van der Heide, which is pretty standard in most RCTs in psoriatic arthritis. The only difference is that when companies do studies looking to show retarded radiographic progression, they are powered to do so, whereas we weren't powered to show that outcome. So TICOPA only had 200 people in total, roughly 100 in each arm. And so you were always going to struggle. And the reason you struggle is that radiographic progression in psoriatic arthritis is not like rheumatoid, where you get an increase in scores of about 10 points per year. You only get a 1 or 2 point change in psoriatic arthritis per year. So you need a lot more patients and a longer time to demonstrate a difference. And in the original publication, we reported total sharp Van der Heide scores between the groups and showed no difference. But only 25% had an erosion, at least one erosion when they were recruited. And that had risen to 35% by 1 year. So very little progression was observed in either group, really. What we've done now...
Yeah, keep going.
Sorry, shall I carry on?
Yep.
What we've done now is a little bit more fancy analysis of the radiographic progression. So we've looked at more sophisticated statistical methods, but we're still not able to show a difference between the treatment groups. Having said that, people getting an increase in erosion score of 2 or more, I think was about 6% in the tight control arm and about 17% in the standard care arm. That didn't reach statistical significance, but it does give you a signal that achieving tight control does help prevent further radiographic progression.
Just remind me, these were relatively early disease patients, weren't they? Which, you know, one of the few trials that actually looked at early disease. They should have been eroding a little bit quicker.
Yeah, they were less than 2 years disease symptom duration. And as I say, only 25% had at least one erosion. But if you look at the spread, I think a handful of patients had more than 5 erosions at onset. So these patients were not, they were in the early stage of the disease, and only a few were going to get aggressive progression. As you know, the more erosions you've got at the outset, the more you'll develop during the course of the disease.
And Philip, did you have a feel for the standard of care really being very good care? Because you're in a unit that's switched on to PSA management?
Of course, yeah. I mean, this was always going to be the challenge because these were our consultant colleagues. They knew of the trial. They knew what the theory behind it was. They'd been treating rheumatoid to target for years. Yeah, they're very switched on and were reasonably aggressive. Having said that, in the standard care arm, I think only 8% went on biologics at 12 months compared to about 37 in the tight control arm.
And was there a difference in prednisone dosage? It's never very high in PSA, but did they resort to more steroid because they resorted to less biologic?
Not really. And that was an interesting thing that compared to the current study out of Leeds, the Gold-Metzer study, which we're not discussing today, the amount of steroid we used in either arm was minimal, really. We were interested in whether it caused a flare of the skin, and we published on that subsequently. And there was some evidence that your skin outcome, as measured by PASI, did worsen after a bolus depot injection of steroid. But neither arm really got enough to make a big difference, I think, in these outcomes.
Well, that's very interesting. Most of the clinical trials seem to have somewhere between 10 and 20% of people on a low dose of steroid. Not the 50% of rheumatoid, but still, a modest percentage.
Yeah, and none of ours were on oral steroids. These were people who were given a depot injection to try and tide them over in terms of disease control until the DMARDs kicked in.
Was there a difference in injected between the two arms in favor of one or the other?
No, not at all.
Interesting. Now, use plain X-ray, which is not that sensitive because they don't erode a lot. What's your feeling about ultrasound in psoriatic arthritis management and MRI as the future?
Well, we had 80 patients who had extensive ultrasound and peripheral MRI in this study. I published on that group of patients about 4 years ago. And interestingly, using MRI and ultrasound, you were unable to show a difference between the treatment groups. We were able to show improvement within group in terms of things like ultrasound, power Doppler signal, and MRI synovitis. But there was no difference in structural change in either group over that time. And it's interesting that there was not a lot more disease seen in ultrasound. We've published on that as well, but it's quite commonly reported in rheumatoid that there's a lot of subclinical ultrasound positive joint inflammation. But in this study, and whether it's because of the group of patients we saw or because we've got such sensitive fingers, Laura Coates and I, there was very little extra disease identified by ultrasound or MRI in this group.
What's your feeling about ultrasound in PSA management, Philip? Should we be using it as a tool or only in certain circumstances?
Oh, now you're asking, and you're asking this because I'm a dinosaur. My colleagues, the trainees, come from Leeds to Bradford, where I do most of my clinical work, and they're asking for ultrasound in everybody, and I'm saying, what's the point? Even in the ones who've got clinically obvious disease, it's a habit that has been beaten into them because in the clinic in Leeds, there's a little room round the corner where everyone goes and has an ultrasound after they've seen the doctor or before. Obviously, that's a luxury that we can't afford can't be afforded anywhere else. And I try and teach my trainees that what you can feel beneath your fingers is more important. And don't forget, all the trials that have been done on drugs are all based on clinical outcomes, not ultrasound outcomes. So That's what we should be being guided by. I will use ultrasound in the rare circumstance where it's difficult to identify, people who are perhaps overweight, or where it's critical as to which part of the anatomy is inflamed. But on the whole, I can live very happily without an ultrasound machine.
You're not a dinosaur, Philip. I have to agree with you for the first time in a long time, because we only ever do it in the non-responder, where we want to know, is this subclinical synovitis that we're not finding, or that patient we want to de-escalate therapy. And we know if there's subclinical synovitis, they'll flare. So, we don't use it on everybody. I'd understand if it's in a research center for research purposes, but in the non-responder or the patient with very inflammatory story, but normal acute phase reactants, nothing defined, but it's convincingly inflammatory, we look for subclinical synovitis or power Doppler signal. But, those aren't common situations, really.
Agreed.
And MRI in the future, but in a small subset of patients where, the label has to be, it stops radiological progression, so they're very keen to show that. What do you think about a subset looking at MRI and response to therapy?
Well, if you'd asked me that question a few years ago, I would have said yes, then that's an important thing to do, a study to do. But if you look at the outcomes of TICOPA using that peripheral MRI scanner, and okay, it's only 0.2 Tesla, it's perhaps not as sensitive, and the resolution isn't as great as a 1 or 3T scanner. But if you look at the TICOPA outcomes paper, it didn't give a lot of extra information other than what you had clinically. So I'm a little bit skeptical. I did, in fact, propose such a study to the makers of a particular oral drug many years ago, if they wanted to show retardation of radiographic progression, but they didn't want to do it because they feared that it perhaps wouldn't confirm the efficacy of their drug. I'm not mentioning any names, but you know what I mean.
Fair enough. So what about a take-home message, Philip, for the clinician? You couldn't show a difference, and that was statistically significant, but it wasn't powered, and there were other issues. What's your feeling about what we can take home from a very important study? Because the critics would say, well, if you don't have a radiological difference, is the difference clinically important? And, you could ask about, was a different rate of response? Do they have more pain for longer using one arm or the other arm?
I think the results of TICOPA all the way over the papers didn't show a difference, but a signal of a difference. And what we haven't talked about is that latest paper of ours, that although there was no difference between the groups, the people who progressed were polyarticular, had a CRP, were erosive at onset, and had dactylitis. And you were less likely to progress if you hit the treatment target, which was MDA, in either group. So I think that's the take-home message. If you can treat the target and get them into low disease activity, they will not progress in the same rate as if they weren't hitting the target.
And I think that's critical, really. You're saying that the predictors of progression are the things that we should be on the hunt for, and they're the ones we should really make sure we treat properly.
Yeah. We have to abrogate inflammation, as the saying goes, to prevent progression. And it's really the same story as in rheumatoid. The other thing to mention, of course, is that the radiological changes in PSA are a bit different to rheumatoids. So it's not all destructive. There's new bone formation as well. And the modified sharp Van der Heide doesn't account for that. And we didn't really score it. But if you use techniques such as micro CT, like Jörg Schett does, you can show an effect on the new bone formation as well in terms of your treatment effect. we didn't look at that.
Excellent. So the future with the TICOPA, any more to mine from that study to give us a strategy for the treatment of PSA? And when are you going to start the exact same trial, but with some of the modern biologics?
Well, the modern biologics. Well, as you know, Elena Marzo-Ortega has just conducted a study with golimumab and methotrexate, negative result.
Yes.
We did a long-term follow-up of TICOPA to see what it was like 5 or 6 years after the completion of the trial. And in fact, the standard care group had caught up in terms of clinical outcomes and drug use. So unless you carry on treating to target in a very careful way, then your outcomes are going to lapse.
Okay. And no more future TICOPA type studies on the horizon?
Not from me. Hard work to do these things, you know.
Fair enough. Well, thank you so much. I think it's been very important, land-breaking study, and we should continue to keep an ear to the ground about what Phillip Helliwell and his colleagues have to say about that strategy study in the future. If you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available at imidforum.com. Please subscribe to the podcast on Spotify, iTunes, or other podcast media. Let us know what you think. You can also watch us on the IMID Forum on YouTube. Finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the new data as immune-mediated inflammatory disease content is coming soon in 2025. So thank you for your time, Phillip. We do greatly appreciate it.
Thank you.